Hi.
Hi, is this Ravella?
It is. Hi.
Hi, it's Neelam here again.
Hi, Neelam.
Call to you. I'm gonna put you on hold until I connect with Karuna, okay? Just
Okay.
hold. Thank
Okay.
you.
Jess, can you get me some hot water?
What?
Can you get me some hot water?
Do you have record for the set up calling?
I'm on the phone right now. Yeah, I do.
Hey, hello?
Hi. Hello.
Hello?
Hi. Hi, doctor.
Hello?
I can hear you both. Yes. Can you both hear me? Okay. She hasn't said yes yet. She's having some trouble.
Hello?
Is she nearby? Okay. I don't know what's going on. I just got disconnected. Now I'm waiting for the phone to ring.
Community Health Centre on Mark Rico.
Hi again. How are you?
Hello.
Hello, doctor.
Can you hear?
Yes, we can. Can you hear us?
Oh no, she can't hear us again. She has to combine the calls. Excuse me. I'm a burpsicle waiting for a call from esta doctora. Hallelujah. Hallelujah. Okay, here we go. Hello?
Hey, Nirmala. This is Dr. Abu here.
Okay.
Hey, I'm going to try and merge our calls with Neelam here on my end, okay?
All right.
Just hang on here, and hopefully this will work. Okay, hello.
Hi.
Neelam, can you hear us?
Yes, I can. Thank you for
Yay.
showing up.
Oh, great.
Okay, no problem at all. Yeah, it looks like everybody's online here.
Yep.
Yeah. Okay, so if you guys are okay, I can go ahead and start this.
Yeah, go for it.
Okay. So Nirmala, we do receive your complaint form, a formal complaint written on November 3rd, and we validate your concern. And I know your main concern here is like you need a provider that look after your medications and then try to adjust those doses. So I'm just gonna let Karuna speak about it this first, and then we can come up to a conclusion. Okay?
Okay.
Sure. I mean, just to back up, I've not, don't know if it was emailed to me or not, but I don't think I have a copy of the concerns here.
Okay.
So I don't really know how to respond to them without really knowing what the contents of the complaint are.
Okay.
Have you not read it?
If you, I can forward it to you. Right?
Sure, yeah, I've got my email open, so if you want to just forward it to me, I can look at it right now.
Sure.
You haven't had a chance to look at it before?
No.
Oh, okay.
Because it comes to the management, Nirmala, so it's with us, and we usually do not put your complaints, like any client's complaint, in their files. It's under our management.
Oh, okay.
Document.
There was a checkbox on there that said if I minded it being shared with the doctor, and I said I checked it and I didn't mind.
Okay, on your way, Karuna.
Okay.
You?
Should be here. Okay, got it.
Okay.
Okay, one sec, folks. I will just have a look here.
Okay.
I believe the main overall concern is like Nirmala wants most is to have like a physician that he can speak with about his medication, and he would like to involve his physician and interest in his health and specifically situation that he's in a complex pain.
Okay, just having to read through here real quick.
Okay.
Okay, so, yeah, sorry, so, where do you want to start here? Do I just...
I'm not sure.
You want to like clear your side, like what you think about this and how you feel about this?
Mm-hmm. Yeah, so, yeah, I appreciate that you raised some concerns here. Nirmala, I think, you and I have also had numerous direct conversations about your pain and my comfort in being able to support you in this. So you have been in my care since about January of this year. Previously, you were followed by Dr. Hay. And I believe at the time when you switched clinics, having a primary care provider in the community already, you were looking for someone who is a little bit more accessible or responsive.
Yeah. Sorry, go ahead.
Yeah, so, and I believe at the time when we met, which I routinely discuss with most of my patients, while I am more accessible in some ways, the waiting time to appointments is pretty long at this clinic, including my patients, up to 2 months for a regular appointment. And that is a pretty standard thing that I discuss with all patients at the first time I meet them, because I know that that's a very long way to go between appointments. So, I think that one, I don't really have a great way of addressing that, right? Like, all of my patients have to wait that long between their regularly scheduled appointments.
Okay.
Aside from more urgent matters. Now, what is considered an urgent matter or a change from baseline really depends on, the person and like what they're coming with. And I appreciate that you are actually very good at communicating when you feel like something cannot wait and you need to be seen sooner. You've had many conversations with our nursing triage, and I think that is good. I think from my perspective, what is sometimes difficult is frequently the thing you're calling about is pain, which I think in your case has been the most challenging aspect of your care to date. And most of the time, there isn't a quick fix for this, right? Like, I'm not sure how us like responding to that on the specific day you call most of the time, not all of the time, but most of the time, I am not sure what exactly the hope is from those visits. Tied to this is just the questions about hydromorphone and your other pain medication, right? So when I met you, you were and have continued to be followed by the physiatrist, Dr. Andrei Krasikov, who has been seeing you for spinal cord injury-related chronic pain for a while now. I think, correct me if I'm wrong, but a couple of years.
Yes.
Is that correct?
Yes.
And I've been referring to him as your pain specialist. He is perhaps not technically that, but he is a spinal cord injury, like specialized physiatrist or rehabilitation specialist who has been managing your pain medications to date outside of the opiate pain medications. So gabapentin, the creams, the lidocaine creams, all of that, other previous trials of medications you've had, he has been the one initiating that and making plans with you about how to proceed with them. So when I've been referring to your pain doctor, I mean it in that way, that Dr. Krasikov, having some expertise and experience in working with people with spinal cord injuries, has been trying to make these plans and trying to adjust things over time. And then I have been prescribing hydromorphone for you, kind of picking up where Dr. Hay left off, because he had started prescribing you that before you were a patient at Rise. And then I have continued that. I will acknowledge there has been a change to the dose, as well as the frequency with which you are being dispensed this. So, at least from what I can understand, before you came to Rise, you were filling hydromorphone 31 milligram tablets approximately every 1 to 2 to sometimes, a little bit more than that months. And I can document that by looking at Care Connect. I can see you filled 30 tablets in September of 2023.
Sure.
Then on November 1st, you filled another 30 tablets, so approximately a month later. Then, Dr. Hay gave you another prescription of 30 tablets on November 28th. And then you went all the way till January 10th with another 30 tablets at that time.
Sure, yeah.
Like a much more variable and a little bit more spaced out quantity.
Yeah.
But then sometime around July of 2024, because I prescribed you 30 tablets in January, and then I didn't prescribe you hydromorphone again until June. So a 6-month period, you subsisted on just 30 tablets.
Well, actually, I was using the one the ones I was getting before. I wasn't even using, so I hadn't even paid attention. I was just using them up, and then when I called you was when they ran out. Yeah.
But it suggests either way. It suggests that something changed.
Right.
And
It did.
In June, I have been filling somewhere on the order of 20 to 30 tablets. More recently, just 20 tablets.
Yeah, it's been
Every month, if not sooner than that. So July 17th, 28 tablets. Then July 26th, another 20 tablets. Then August 15th, 20 tablets. And now I have, discussed with you, okay, we're going to only dispense you a set number every 4 weeks, just to keep it regular. So that we're not running into the issue of like, okay, we're prescribing potentially a significant increase in pain medications within a single month, right?
Okay.
So at least that was my hope. My hope was that, okay, we could get into a regular pattern of this is a reasonable quantity for you to use over the course of a month. And I was prescribing it that way on the understanding that previously you weren't requiring a heavy amount of dilaudid. Like, as you said, you were barely needing to take it. So for me, that kind of raises the question of what happened in June that suddenly your requirement for hydromorphone dramatically increased.
Okay. Here's what happened. I wasn't taking the amounts that I was getting occasionally from Dr. Hay before in the full amount. So I had a backlog of them. And then when I switched doctors, I didn't really pay attention. I didn't ask you to fill them repeatedly at the beginning because I was just using up what I still had, and I thought that it would be the same as it was. And basically, my understanding is a bit different from what you just described, which is that I had a prescription where I could get 30 per month and as needed. So if I needed it and it wasn't a matter of, oh, you're using more now, or you had 30 a month, and if you need 30 in the month, then that's okay. If you use 20 one month, then that's okay. If you don't fill them this month, that's all right. If you suddenly need to are using 30 a month, that's okay too. That's the understanding that I was assuming that it was, because I'm not, from my point of view, I'm not a high-risk drug increaser, because I don't really favor using it, and I practically die before I'll increase the dosage. So, and when I was using at that high level, what you just described, the most I was using was 1 milligram per day. That was the most I was using. And I would have to cut the pill into fragments, and then I was taking them, and I was having a lot of pain. And if anything, the pain is more now, but I've become better at just gritting through it. But it's not like it's getting better. I definitely wouldn't say that. And what I wanted was not for, and I want to know if this is a systemic problem or just a problem with the finances of the government. Because if I were a rich person and I had a doctor, I would not expect the same kind of relationship with my doctor. But I'm not rich, and I have an account with this. I would expect a relationship in the sense that my medication, I want to be trusted. My word, I want my word trusted. When I say what I say about the way I take the drugs, I want that to be taken seriously. I don't want to be expected to increase. Why? Because I'm getting more strapped on the drug. If I'm increasing, it's because my pain is really high, and I fight. If I take it for 3 days in a row, and then I no matter whether I'm going to die the next day, I don't take it. That's how that's how serious I get with it, and I have to fight with high blood pressure for hours sometimes, just to not take it. And then I'll take like 1/8 of a milligram and I'll spit it out halfway through because I don't even want to finish it, So that's how I take it, and it's not, I don't feel that that's a stable way of taking it. If I went to the hospital, they would say that I was crazy. They would say, no, take as much as you need to get rid of the pain. But I do it the way I do it because I have experience. And I don't know if I'm doing it right either, but I certainly don't want to, like I said to you before, I don't want to start taking it and then suddenly be like, oh, you can't get this anymore, right? And I would just as soon go outside and let nature take its course. When it gets to that point, and I have gotten to that point, the only reason I don't do that is because I have loved ones around me, and I don't want to put you, doctors, everybody, the whole team. I have a team of people around me that are working to try to help me, and and God as well. I have God, and I know that whatever takes place, I'm not going to question the plan that He has. So that's how I see it. And I just wanted more from the relationship in terms of the one aspect that I mentioned in the letter as well, which is as a team member, somebody who is going to take, I don't know, half an hour. Put it this way, if I was a doctor, and I might have been if I hadn't had the history that I went through, if I was a doctor and I had a patient with my condition, I would want to know what the latest was on that. I might just subscribe to a discussion group about that subject matter. Well, maybe that's too much to expect in today's day and age. Maybe I don't have the funds to expect that, but I certainly would expect that from my doctor if I could afford it. So that's where I'm coming from. I'm willing to accept that I have no doctor. I'm willing to accept that even. That I'm my own doctor and I just get the pills when I get them as much as I can, and that's okay. That's the way, I have a relationship with Rise Community Health, and it's been very good to me, much better than my previous relationship with my doctor, even though that one was really dysfunctional. He would call me at 2 a.m. and swear at me. So not at me, but just be get off at work, and it was very jarring, and I didn't, anyway, there was things like that. So I wanted to have it a professional thing where there's other support from you guys. I've had diet help, I've had social work help, I've had other help that's been very helpful. So counseling help. So and with the doctor, I'm just describing what I had in imagination. Imagine what it was, what it could be, and because I don't know what the latest is. I don't know if there's any late. Maybe there is none. Maybe all I have to hope for is taking a gabapentin or pregabalin, and then just hydromorph here and there until I can't go anymore.
Yeah, if I can respond to all that. So 2 things that I'm hearing here is, firstly, this part about, my personal investment in trying to find you some answers here. I would argue that I have spent a considerable amount of time exploring what options exist. What I am not willing to do is I am not willing to entertain unproven, unscientific means of treating spinal cord injury-related types of pain. So I am capable of evaluating what evidence exists and what has strong, blinded trials behind it in terms of evidence for this kind of pain. And the truth of that is that agents like gabapentin and Lyrica and other tricyclic so-called antidepressants like nortriptyline have reasonably good evidence behind them. And what does not have good evidence behind it for this kind of pain, the kind of pain that you have, is opiates. They have very weak evidence, in fact. And so the fact that you're being prescribed this at all is a bit out there. It's actually not evidence-based.
Yeah, however...
So, please let me finish. So, this is where I can invested some time into looking into answers here, but I am not capable. I do not have capacity in my day professionally, and certainly outside of my professional time. I am not able to put in more time searching for other or more experimental solutions for this. And that is true of any patient with any condition here.
Okay.
I can do what I can do, but there are limits to that. And I am not a specialist in pain. I don't have a ton of experience with people who have suffered spinal cord injuries. So from my perspective, I have tried very hard to find some solutions here to look at that evidence. And the evidence is telling me that probably your best bet is gabapentin, Lyrica, and those related drugs in those families. And that is the best that modern medicine has at the moment. So that's the first part. That's responding to, my ability to, look for novel solutions here. And the short answer is my capacity for that is limited. It is not nothing, but it is limited. Secondly,
that's what I said.
Secondly, regarding the hydromorphone thing, so I think it's reasonable, if you want to use a certain quantity of these tablets throughout a month. I think that's a reasonable thing. I'm not disagreeing with you there. And how your prescription is written is 21 milligram tablets to use up to a maximum of 1 milligram a day, a full tablet a day as needed. So on days you don't need it, don't take it. On days you need it, you can take it. And there are some ways we can adjust that a little bit. So for example, if you wanted to do 30 tablets, 31 milligram tablets per 4 weeks, that would be okay. But there has to be some limitation on how frequently that quantity of medication can be dispensed to you. So you can't call me up every, second week or something, or even...
I don't. Have I done that ever? One time I called early because it was a long weekend, and I wanted to make sure I didn't run out by the... that was why I called early.
Again, I can see that your pharmacist filled, I've received multiple previous...
And you know how many I have in my cabinet? I have 60 or 90 or 80 in there. Honestly, I have, yeah. So, it means that I'm a disciplined person. After listening to you, okay, I have to calm myself because I want to respond.
So what I'm suggesting is, so if you're not using even 30 tablets a month, if you're not using 1 full milligram, why am I continuing to prescribe it with that regularity? I think
because my pain goes up and down. If I need it, then I call you and you don't give me any trouble and you say, yes, okay, you need it. I'm not going to call more frequently. But here's the thing that I got out of just listening to you in your response was that you're very clinical. When you research, you base all your conclusions on the research that's out there, and you're not willing to take any chances with new treatments that are out there. Okay, I get that. And also with your time, you are very restricted with your time with me. You'll spend the time that you have, and it's not much. It's spread between your other patients, and that's it. Okay, I accept that. But where I have a difficulty with is that I don't see you showing any regard for my statement of how these drugs affect my body. I can tell you specifically how the hydromorph, how I take it, when I take it. I have a logbook that for the last year that you can read if you want, to see how I deserve to be taken as seriously as the research that you did. So yeah, that's all. My experience is as valid as the research that you do. I have a lot of experience with gabapentin. I have a lot of experience with all those drugs that you mentioned, except Lyrica. I haven't tried that one yet. And I know how it affects my body. If I tell you how it affects my body, it just goes right over your head. It feels like to me. right? It feels like the research that if the research that you read contradicts or does not take into account what I'm saying, then the research trumps what I'm saying, and that's okay with me. I'm perfectly okay with that.
So what happens here, Nirmala, is yes, you're saying that gabapentin doesn't work for you, or you want to decrease the dose. But historically, what has happened is
I need to be trusted. I have to be trusted.
Different doctor. You make a plan with a different doctor, Dr. Krasikov, and then typically you have an appointment with me soon after that, and then you ask me to make a change to medication he is prescribing, which I simply will not do.
Like which one?
That is crossing boundaries of my relationship with Dr. Krasikov as well. So
which change did I ask you to make with the gabapentin?
Let me find a specific date. I did start that. Hang on.
I asked for a change in the brand.
There are 3 different types, 3 different books.
Shh, Dad.
They don't know that.
Shh.
So anyway, let me look here.
Okay, I would like to put a highlight on this one, like our policies for the opioid and controlled substance use clearly says, Nirmala, like it needs to be reviewed on the regular basis that you are trying to do, but like if you are not using it, I don't think so.
I don't know how many I have, but the thing is, I quit because I went through this. Okay, the doctor just told me that it's under clinical evaluation. It doesn't work. Well, I can tell you that it does work. Okay, then we have a difference of opinion. I just want my opinion trusted. I use it as needed. When I use it, it works. Sometimes it doesn't work. He's right. It's not reliable under a clinical. I can agree with that, and it's not reliable for everyone. And probably Dilaudid is not the best. There might be another narcotic that works even better that I don't know about. But you're.
Let's listen to Dr.
Okay,
Yeah,
I'll listen.
So, I do appreciate that, yes, in your personal experience, you're maybe having some benefit. But there are some boundaries here, right? Like, say, for example, you were like, you know what, Dr. Abu, 1 milligram isn't cutting it for me. And I'm not saying you...
Have I said anything like that ever?
No.
And I'm not going to.
Nirmala, I'm not willing to, like...
Okay, sorry, I apologize.
For the sake of example. So, let me talk about a separate patient, okay? Not you.
Okay,
patient,
another patient, yes.
Okay, so another patient, similar situation. They say to me, hey, I've got chronic pain. Let's try these opiates. And I say, okay, sure. We'll start a low dose of an opiate like hydromorphone and see how you do. And it does help them to some extent. Then, maybe a year, maybe 2 years down the road, they come back to me and they say, you know what, that same dose isn't really doing it for me anymore. I need double that dose or triple that dose. And so maybe I, at that time, did agree to that, and I tripled their dose. Okay, I won't say how much they were getting, but I tripled their dose. And slowly, after several more months, okay, even that's not cutting it. Now I am starting to get very uncomfortable with the amount of an opiate that I'm prescribing without clear, good evidence that this stuff is safe and effective for this person.
I'm with you 100%.
And this gets tricky because then we get into the situation of, well, they're saying they need more, and the expectation is that I am just going to prescribe more.
That's right. That's not good. I know. I agree 100%.
I'm not a vending machine. And literally there was a hydromorphone vending machine in downtown Vancouver, but, if that's what many people want, but I am simply not that, and I'm never going to be that.
Okay. I didn't appreciate being assumed that that's what I was right from the start. I felt that you had assumed, now that you mention it, that was an assumption right from the start. Now, maybe that was because you had that experience in the past.
No, I'm not assuming that that's going to be you, but those kinds of cases influence how I practice now.
Okay, that's
right?
fine. I would like a higher level of trust. That's what I would like.
But it's not really about trust, Nirmala. It's
to
about
me
coming
it is.
to common ground here where I am not saying I'm not going to prescribe you hydromorphone, but I want to set some boundaries and limits around how much and how often, right?
Absolutely. You don't even have to prescribe me hydromorphone. It's not about hydromorphone. It's about the trust. It's about trusting my voice, my word about what I'm doing, why I'm doing it, my experience. I have 38 some odd years of experience as a quadriplegic. I have been addicted to morphine at a high level. I've gotten off. I've had seizures before. I've taken drugs. I've been clean. I've been through so much. I've traveled across the United States twice in a camping vehicle from across the north, across the south. I've done a lot with my body and with my mind and my abilities. I have a 30-year-old daughter, and she lives in Florida. So I'm not, I just would like to be trusted, and I would like to feel like I'm trusted. That's all.
But I guess what I'm wondering is, so trust is a very nebulous thing, right? Like
Okay.
I think clinical practice and trust are two different things. So
Okay.
we have to find a way for those two things to meet in the middle. And so, what I can do for you really is agree with you that, okay, I'm going to provide a certain quantity of tablets of, in this case, hydromorphone. And because that is, of all your other medications, that's the most controlled one, right? That's the one that I have to be able to defend why I'm prescribing it and in what quantities. That's my responsibility. So we just need to agree to.
Okay, I have no problem with that.
You're going to get, and you're going to get them every 4 weeks, or if you prefer, if you're not using them.
I would prefer, whenever I need them, I'll just call, and then I get 20 or 30, whatever. That's all I prefer.
Yeah. However, okay, so here's the other side of this, right?
There has to be a limit. Absolutely, I agree.
There's a frequency, right? So, we need to agree the minimum interval is 4 weeks.
Absolutely, I have no problem with that.
What is nice about me prescribing you a set number every 4 weeks is that you just know every 4 weeks you're going to get a refill. Whether you use
Yeah, that's good. That's good. That's fine.
Right?
Yeah, that's
Which is what I
fine.
have been doing the last several months now.
Okay.
We just need to be on the same page about that.
Right. Except, however, if I do need to take them more frequently, I'm concerned. I'm just gonna my approach would be that I'm gonna go ask for palliative care, because I don't want to get stuck on, like you said, having to go up. I'm gonna fight it tooth and nail. But if this pain continues to go where it's going, I honestly don't know what's gonna happen. I'm gonna have a seizure at some point in the middle of the night. That's what it's going to lead to, because the only medications when I'm sitting there with my blood pressure up at 160, 170 over 130, for half an hour, you can't just leave it. You have to take something. So I take a tiny bit of the hydromorph. I can't take more gabapentin. That's already, I've been told no by Dr. Kosyakov, because it puts me into a spiral of anxiety and suicidal thoughts. Even if I increase by a minor, can I just explain yeah. So I have the lorazepam and the other one, and the lorazepam is even stockpiled more, because it only takes literally a few powders of that to bring my blood pressure down. But I'm scared to death of taking more than that, because I know how much of an 24 hours later I get a pain attack if I take it more. So even though it does offer me an incredible amount of relief, I have experience, and I try to remember anyway. I have my caregivers, my dad, I consult, okay, remind me what's going to happen if I do this, don't do that. I'm trying to do things as intelligently as possible. It's the only way I've survived to this point. So I would like a higher level of trust, I guess I would say. And I totally respect what you said about the clinical and the trust having to be separated. But, however, it's a relationship, a doctor-patient relationship. And me having this chance to explain myself to you goes a long way. In my own, I'll accept whatever happens out of this. I've already accepted the way it is now. I'm not fighting it. It is what it is. But I would. This is what I'm trying to say was what I imagine would be nice.
Yeah, and I think so. Like, to be clear, so it seems like dispensing you 20 tablets every 4 weeks has been working well, right?
It's fine because yeah.
What happens when you have a pain flare-up? Well, this is going to be very tricky, right? Like, ideally, this is when we are going to use hydromorphone. Like, this should be the case where we're using it. Now, we can talk about other options at future visits about longer-acting opiates, potentially at low doses, but we're really going to get into a need for something like an opiate contract and some other monitoring if we're talking about that.
Yeah, I don't want to even go there. I have no plans of going there. Trust me. I'm going to try the ointment on my back. I'm paying $70 to get this ointment now.
I think the ointment is a very good call. A very good thing to try on your legs, on your back, and then we'll see, how you do with that.
I got the compression sock that helped, but the amount of pain is like you can't even imagine. You can't even imagine.
The truth of it, though, Nirmala, and the really tough thing here is, I don't think we're totally out of, specialists to send you to. I'm happy to try and do that, but like, the kind of pain you have is very difficult to treat, and the reality is,
let's push the envelope. I've got, my body is very healthy. My brain is very healthy. It's better than ever. This thing on my leg shouldn't stop me. I mean, let's push the envelope. I'm willing to go to the ends of the earth myself, but that's all.
Yeah, but I just don't think that there are very good treatments for this, and that's
okay. If that's the way you feel.
Not a curable thing.
No, not a curable, but they're anyway. I think there is, but it maybe hasn't been discovered yet.
Yeah. So anyway, I don't totally understand if we've come to an agreement here, but I think there's some opportunity to have been clear here.
I agree.
Yeah, go on, Neil. I'm sorry.
Okay, no, that's okay. I was just trying to listen to both sides. So what I think is, because you are not taking that quantity, so I believe Dr. Abu is going to still continue to provide you, that's 21 tablets, right, Dr. Abu?
20 tablets currently.
That's fine.
20 tablets. 20 tablets for every 4 weeks. And if there is any flares or anything come up and then you are running short, the first approach would be either to call the clinic and talk with one of the nurses, and then we can help you from that way.
Well, no, actually, let me clarify. So, say you get 20 tablets, but you don't use all 20 tablets in a month, you'll keep some, right? You'll just keep it in your medicine cabinet, and that's okay. Then on days where you're needing more medication, why don't you take what's in your medicine cabinet, the leftover, and we should agree to what's the maximum number of tablets you can use extra from your stockpile, from the old supply.
Well,
you theoretically should never have to call me for additional doses, because if you're using it as sparingly as you're saying you're using it, you should have tons stockpiled. And as you said, you probably have 30 to 60 tablets in your...
Probably, yeah. Maybe 2 months worth.
Okay, so then you and I, so in addition to what I am prescribing you every 4 weeks, we need to just decide, okay, on a really bad day, a crisis situation, how many of the leftover doses can you take? What's the maximum?
Can I respond to that?
Well, let me just say, so what's the absolute maximum amount of hydromorphone you can take before...
I've never taken more than, in the last year, more than 1 in a day. Never.
Okay.
Never. I never take more than 1.
Perhaps it's worth us then saying, okay, Nirmala, if you're having a pain crisis, you can take another full milligram tablet. So say you took...
I can't, though. I have such a restriction. It's like, in racing, they put a restrictor plate so that it can't go faster. I have a restrictor plate on myself that says don't take more. So when I get to that level, I'm like, okay, then I'm just gonna throw in the towel at this point. I'm not gonna bother with taking more because I don't want to go there. I don't want to go there. Like, I don't want to go. I have more fear of it than you have fear of it.
Okay, but then I don't totally understand. Like, if you say you were in that situation, you're having a pain crisis. When you call the clinic, say you call to speak to one of our nurses, what are you hoping they will do for you? Like, what do you want in that moment? I'm really
That's a good question. That's a good question. Okay. Yeah, it's often in those cases I did run out. So but I wasn't taking more than 1 milligram a day. I had run out because I didn't call for a refill in a long time, and then I was using up my back supply at the one, and then I ran out. I just suddenly noticed that I was out, and then I called in at the last minute. But and the other time, so I've never actually used more than one a day, even in those crisis times.
Okay.
So yeah, I would prefer not to. If I call you and I'm like, give me more, put me in palliative care. I don't want to be there. I don't want to be that person. So right now, I don't know. I don't know how to answer that because, like I said, I'm on the border between life and death at sometimes, and I'm doing the best I can.
Fair enough.
Yes.
Because I'm not a medical professional, but do we have any palliative care, resources or something that we can come up, but not at this appointment? We can book something else, but for right now, we can just have this 20 tablets hydromorphine every 4 weeks.
I'm good with that.
He can use 4 milligrams of hydromorphine, whatever he has leftovers with him.
Yeah, I think up to a maximum of Nirmala, let's say, and I know you probably won't use this much, but let's say even very conservatively, you can use up to 2 milligrams a day. You can use the back supply, the old supply, and top up to 2 milligrams a day. But, if it should tell us something, if you've used up your old supply, it should tell us something that,
okay,
it's time for you and I to reassess things and see,
okay,
has your opiate need changed substantially? Because say you run out again of your old supply, it tells me that, actually more days than not, you were actually using, say, 2 milligrams a day. And this is, again, all theoretical.
That's true. That's a good way. Yeah, you're right.
But this is why I'm saying, theoretically now at this point, if everything you're saying to me is actually the case, and I believe you that you are using it very sparingly, theoretically, you should never run out of hydromorphone, and you should never have to call here in a crisis situation needing
That's
more.
right. That's right.
And if you did, well, you can just expect
then I would be in big trouble.
Discussion about it, okay?
Yeah, then I would be in big trouble at that point. That would mean my pain had increased to a super high level, and yeah.
Exactly. Now, you're due to have another 20 tabs prescribed to you, so that's, I'm going to fill that today. So you should get it tomorrow or whenever your next prescriptions are dropped off. So that's, the next 4 weeks supply, okay?
And I'm supposed to start Lyrica tonight.
Yep, and you can still do that.
Yeah, I'm very wary of it, very apprehensive, but I don't know.
Yeah. But, that's a plan you made with Dr. Krasikov, and he really wants to see you try the medications that he's prescribing to evaluate, what happens with them. But,
yeah.
I'm not really directing that part.
Directing maybe not, but observing would be nice.
Observing, but not gonna change it, not gonna, I can't interfere with that, because that's somebody else's plan, and he wants to know the results, right? So if it doesn't work, he wants to know about that. If it works some, well, okay, maybe we've got a path, maybe we've got something to go on, right? So I think his plan was to try that. He just saw you November 6th. I think his plan was to try the ointment and to start Lyrica at nighttime, just for 3 or 4 days, then add a morning capsule. and then he's going to see you in 3 or 4 weeks. So
Yeah.
that'll probably be early December, right?
Yeah.
And I'm like, okay, that's a reasonable trial. If you do what he's asked for the next 3-4 weeks, and it doesn't work, well, that's information for him. You gave it a good shot, and then he can talk to you about, okay, where do we go from here?
Okay.
I'm looking at the time, Neelam and Nirmala. I'm afraid I do have to go. I've got another patient here, but
Yeah. There's only one more thing I would like to say, and that is briefly that I would, on our next appointment, I would like to use it to discuss with you how these drugs affect my body. I would like you to hear from me what's going on when I take them and how they impact my pain and my nervous system, my brain, so on and so forth. That's the only thing I would say.
Okay, and that's fair enough. I think that I'm happy to listen to that.
Okay.
There may not be anything that I can.
No, there may not. No, but at least I would like you to know that.
But I may or may not be able to actually act on that.
I know
I'm happy
that.
to listen to that. Currently, we do not have another appointment booked, so why don't we have the front desk go to that? Yes.
If you want to step out, that's okay. I can book that appointment and
Great.
we'll continue.
Great. And you'll let Nirmala know the date?
Yeah.
Okay.
I will.
Perfect. Okay. Thanks so much. I appreciate that, Neil. And thanks, Nirmala, for your time today. I appreciate that.
Yeah, thank you, doctor.
Thank you, doctor.
Okay. All right. Take care, both of you.
Bye.
Okay, thanks.
Hi, Nilu? Are you there? Oh, I think he was the one who initiated the call, so she has to call me back. Hello? I hope she calls me. Call me, call me, call me. Call me back. Please call me back. Guess she's not going to call me.
Who?
The manager over there, she was on the phone, a three-way call. She wanted to say something to me after he hung up. And then he hung up and I think it disconnected the call.
She would help?
She didn't say much. I want to call.
Hi, you have reached Rice Community Health Center. If this is a medical emergency, please hang up and call 9.
What?
The voice.
Why did it go to voicemail?
Hi, you have reached Rice Community Health Center. If this is a medical emergency, please hang up and call 911. Rice Community Health Center is open Monday to Friday from 9:30 a.m. to 6:30 p.m. Group services and limited pre-book appointments are available on Saturdays from 9:30 a.m. to 5 p.m. Phone lines are open on business days until 3 p.m. No same-day appointments will be available.
Oh man, now they close at 3
If you are a
p.m.
patient or a healthcare provider wishing to speak to any of our staff members, please leave a message with your name, phone number, and a reason of your call.
They close at 3 now. Everything closes early and opens late. 9:30 to 3. That's the hours now, Dad.
Was it the first announcement said that until 5.
Yeah. Now it's till 3.
Hi, you have reached Rice Community Health Center. If this is a medical emergency, please hang up and call 911. Rice Community Health Center is open Monday to Friday from 9:30 a.m. to 6:30 p.m.
Yeah,
Group
6:30.
services and limited pre-book appointments are available on Saturdays from 9:30 a.m. to 5 p.m. Phone lines are open on business days until 3 p.m. No same-day appointments will be available after
Phone
3 p.m.
lines.
If you're a patient or a healthcare provider
That's
wishing to
ridiculous.
speak to any of our staff member, please leave a message with your name, phone number, and a reason of your call, and we will return your call.
I'll leave a message.
If you're calling to book an appointment, please call us back the next business day before 3 p.m. to speak to a staff member. If you're experiencing symptoms of COVID-19 or feeling unwell, we kindly request you to stay
They
home
still
and
have
take preventive
COVID-19,
measures
huh?
to limit the spread of infection.
I thought it would be
Please leave a
COVID-20
message
by
to
now.
reschedule your appointment and do not come to Rice CSC
Been a
in
year.
person
I thought it
until your
aged.
fever is gone. Please note, if you are trying to reach out to Rice CSC Pharmacy, please do not leave message on this voicemail, as messages left related to pharmacy will not be responded back. Please try to call Rice CSC Pharmacy on the next business day. Thank you.
Hey, it's Nirmala Hickey. I was just on a three-way call with Dr. Abu and Nilu, and I'm not sure if I got your name right. Yeah, I was waiting to talk to you at the end of the call, and then the call I couldn't. It was disconnected. Can you please call me back? Yes, please call me back. Thank you. Yeah, that wasn't before. Everything is getting more and more. I guess it's the funding, I'm sure. Anyway, enough appointments for me for the day. Goodbye. And yeah, that's my life. I'm going to upload that. Now the background is my unmade bed. Okay, goodbye.